Thanks for the opportunity to present the work today, and I love coming to this conference. I feel like a bit of an imposter as an emergency nurse, but I'm kind of getting used to the ICU peeps and hanging out with you guys. It's great. I also need to acknowledge Andrew Patton and Dev Mitra, who were co-investigators on this project. So I guess one of the things about emergency care is that we know, and we've known for a long time, that prolonged emergency department length of stay is associated with a whole range of adverse events. So it's associated with longer inpatient stay, higher levels of inpatient mortality, and we know that the NEAT, the 4-hour rule, the National Access Target's been in place for a number of years now. And although the majority of patients do complete their ED episode of care within 4 hours, the NEAT target does raise concerns about, are we moving patients from the emergency department to the ward before they're ready or while they're clinically not quite stable to go to the ward? So there's a whole lot of, I guess, suppositions and issues related to the 4-hour rule. So the aim of this study was to really look at the relationship between in-hospital mortality and emergency department length of stay, ward clinical deterioration, so by that I mean a medical emergency team call or cardiac arrest team call, and emergency department length of stay. And we also wanted to look at the relationship between in-hospital mortality and time to bed request and time of movement of the patient from the ED to the ward. So it was a retrospective cohort study using organisational data from Eastern Health. So Eastern Health's one of Victoria's largest health services and clearly is in the east. We have 3 acute care hospitals with emergency departments. 2 of those hospitals have intensive care units. And we looked at all patients admitted to non-monitored wards within 8 hours from July 2013 until March 2015. So we excluded patients admitted to the coronary care unit, telemetry unit, intensive care unit and high dependency unit. And we grouped the patients into 3 groups. So the first group was patients who'd been in the ED for 3.5 to 4 hours. So they're the group that we hypothesised that let's go and meet the 4-hour rule group. So, you know, they get to 3 hours and 55 minutes and you've got someone going, go, 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 go to the ward, we've got to meet this KPI. And we compared that group to patients who'd been in the ED from 0 to 3.5 hours, and then patients who had blown their 4-hour target and who were in the ED from 4 to 8 hours. And like I said before, the outcomes that we were interested in were mortality, medical emergency team and cardiac arrest team calls within 24 hours of hospital admission. So it was a bit of a process wading our way through organisational data. So we had 84,000 patients admitted to our hospitals in that study period of time. Like I said, we excluded the groups that went to monitored areas. We excluded children. We excluded patients who had an ED length of stay of greater than 8 hours, and the reason we did that is that they've actually got a very different profile, so they really weren't helpful in trying to answer the question we were trying to answer. We also excluded patients who were transferred out of the ED within 5 minutes because the likelihood was that those patients would be direct admissions and they just happened to, you know, stop for a nanosecond in the ED while the clerks did their paperwork and that kind of stuff. So the upshot of that is that we had just over 24,500 patients included in the study. So we had 2/3 of patients had an ED length of stay more than 4 hours, 18% had an ED length of stay less than 3 hours, and about 16% had an ED length of stay of 3.5 to 4 hours. If you look at the patient characteristics, even though these are all statistically significant differences, that's purely because we had such a large sample. So if you look at the graph, there's actually really nothing significantly different about many of those percentages. So the gender mix was roughly the same between the 3 length of stay groups. The ATS categories are the triage categories. So triage category 1 is to be seen immediately, so cardiac arrest patient. Triage category 5, patients can wait for 2 hours, so they'd be a non-urgent group. So the distribution of triage categories was pretty similar. Just under half the patients in each group came to hospital by ambulance, and most people lived at home. So we didn't have a lot of patients coming from residential aged care or supportive care environments. If you look at the in-hospital mortality, the mortality rate overall was about 2.2%, so that's about normal. But what we found was if you were in that 3.5 to 4 hour group, your mortality was actually lower when we compared it to the other two groups. So you can see the purple bar on that graph. If you had a short ED length of stay, less than 3.5 hours, it actually didn't impact on your mortality much at all when we compared it to the 4 hour group. And we adjusted that for a whole lot of patient characteristics, so triage category, age, gender, whether you came by ambulance and where you lived. When we looked at deterioration, overall about 3.3% of patients had a medical emergency team or cardiac arrest team call within the first 24 hours of hospital admission. The numbers were so small we couldn't really do much else with this data. We couldn't do any predictive modelling, which was a little bit of a shame, but anyway. But what we found was that the longer you were in ED, if you look at the graph to your left, the longer that you were in ED, the higher the likelihood of you having a rapid response team call within that first 24 hours. There was really within your hospital admission. There was no significant differences in patients who had an early MET call within the first 24 hours. So then we looked at time to bed requests and in-hospital mortality. So what we found was that in-hospital mortality increased if there was delayed ward transfer. So in the emergency department, the decision's made to admit the patient, and the best marker of that decision is the bed request. That's probably the surrogate measure of that decision making that's recorded in our information systems. And so we looked at time to bed request as a proxy for we've decided you need to come to hospital. And then we looked at when the patient physically left the emergency department to go to the ward. And what we found was that if there was a delay between between the bed request and you leaving the emergency department, your mortality went up anything over 3 hours. And we compared that to less than 2 hours. So if you've got people that need to be somewhere and they're stranded in the emergency department, our data is suggesting that that's actually not great for the patients. And again, we adjusted that for a whole lot of patient characteristics. So I guess the strengths and limitations of our work, look, it is a single site study, but we did do the study in 3 very different hospitals within the One Health Service. It is retrospective, it is organisational data, so there's issues with that. And there is the possibility that there are confounders that we don't know about that aren't in our data sets. But what we do know is that patient outcomes were better if the ED length of stay was less than 4 hours, and the time of bed request to ward transfer was less than 3 hours. So actually moving our patients through the system, as much as it causes us all a great degree of angst, seems to be better for the patients. And all the literature around the 4-hour rule suggests that it is actually better for patients. There's no massive increases in mortality, and certainly some of the work we've presented here in the past shows that patients do better if they get to the ward earlier. We know that there's safety gains from reducing ED lengths of stay. No one needs to be or wants to be in the emergency department for hours on end. But maybe those gains can be better improved by moving patients to where they need to be earlier. And I guess what we need to do is some prospective work now to better understand if the safety gains that we think we're seeing are related to timely ward transfer or due to reduced length of stay or a combination of both. I was having some conversations yesterday, and I think one of the things that's coming out of this work is that when patients get admitted, the medical care plan is usually pretty straightforward. So the home team will document what medications need to be given, what the treatment plan is, but no one's actually talking about the impact of specialist nursing care. And I'm an ED nurse and I love emergency nursing, but I tell you what, if you've got a hip fracture, you want to be with the orthopaedic nurses, you don't want to be with us. If you've had a stroke, you really want to hang out with the neuro nurses because they'll do better than we do. So I think part of me thinks that some of this data is about getting patients to specialist nursing care as much as it is getting them hooked into the specialist home team. So I'm on a new mission to do some more research in that space now. So we've just published this stuff in Emergency Medicine Australasia if anyone wants to read it. So thanks very much.